Well, friends, welcome to today's webinar. And today we have Dr. Nirmala Rege. She will be presenting on communication skills. Over to you, ma'am.
Thank you, sir. Good evening, everyone. Last time we discussed about one competency, communicate with the patient regarding optimal use of therapy devices and storage of medicine. And if you look at it, it is this competency belongs to attitude or communication. It is shows how is the level, and it has been mentioned that there should be small group discussion with the assessment with skill station. And therefore, I thought that I will share with you something which we have developed before this competency curriculum came in. Because last time while discussing, it was mentioned that we should have repeated sessions. It may not be at one time. It can be at different space. Yes, you can have it such type of sessions at different pace after few topics in the curriculum are covered, and you can develop it. But something which requires more than that, where to have the placement, I thought I will share with you my experience. And this was done, as I said earlier, before this competency curriculum came, and it was a part of my project for FAMER fellowship. So this we tried to develop that time as a structured program for communication skill learning using simulated patients for second MBBS students. And along with me, Dr. Rakhi Tripathi, who is an associate professor from my department, she was with me as a co-investigator, and Dr. Santosh Salagre, who is a associate professor from Department of Medicine, was there. And because it was a FAMER project, there was a project advisor who helped us to develop this. And it was developed in 2016, and we are using it till date. So last 4 years, we have developed experience with such type of module, and I thought that it is quite doable thing. No, why we wanted to do it, though the MCI guidelines were not there, because it is a we know the consequences of inadequate communication of prescription to patients. There are lots of evidences in the national and international journals regarding this, and we have to train students
Ma'am has gone on offline. Hello? Please wait, we are just connecting with ma'am again.
Can you hear me now? Hello?
Yes, we can hear you.
Yeah. So I don't know where it stopped working, but I just will repeat this last two things, that there is a need to train medical students, and we have been training them for the selection of appropriate therapy and writing prescription, but not we didn't find any pharmacology program which emphasizes on the last one. And therefore, we decided that we will develop and implement a structured program for second MBBS students. As I've mentioned, told to you earlier, can you hear me? Yeah. So we have to have learning objectives, we have to have activities and assessment, and all these three should be in alignment. And those who have attended CISP, it has been told to you that because this is a new curriculum, that you have to think about the evaluation. Anything, any educational program we want to put it into practice, it has to accompany with the evaluation of that program, because that will tell you how the faculty and students accept it, and how whether it is worth continuing it or you require to make some modification. So we developed our specific learning objectives for this, and it was that we decided that this will be in the form of practicals, and we have designated 3 practicals for that, because there was a lot of time available during the practical session. And after a set of practical which are supposed to get completed during in a semester, we used to use that particular time for the small group discussion. So we thought that we will utilize that time only and have it as a practical in the journal. So our learning objectives were to state the consequences of inadequate or inappropriate prescription communication, state components of effective communication, identify the barriers in effective communication, communicate a written prescription along with the relevant matter about the prescribed medication to in a specified time to a simulated patient presented with specific symptoms and signs and stated condition in an effective way. And we formulated this because we did some earlier baseline work, and we found that it is because the OPD and are very heavily loaded with patients, it is very difficult. And even the doctors or the clinicians who are sitting in different OPDs, they don't communicate the prescription to the patient, except that they may tell them about little bit about the regimen, but not in detail. So we decided that with discussion with many clinicians, we thought that 4 minutes we should give to the students to inform about the prescription. If we keep a period of half an hour or something, which will not be a practical one also. And we decided to use the simulated patient. And because these are the second MBBS students, we thought that along with the symptoms and signs, we should tell them the diagnosis also. And then we use the appropriate modes of non-verbal communication, use simple jargon-free language that a standardized patient or the simulated patient understand. And we developed a 5R structure, and I will tell you what that structure is while communicating the relevant information about the prescribed medication. So after developing this MCQs, we went to the activities. Now, when one has to develop such type of different educational program, then we thought over here it should be clinically relevant, and therefore we should develop the clinical case scenarios based on clinical scenarios, and those should be selected and they should be developed. We have to train our faculty, our residents and students, and residents because we decided that they will act as a standardized patients or the simulated patients, and we should assess it. So there should be some assessment measures. We have to think about the program logistic, how to implement it and how to evaluate it. So for the case scenario development, the faculty in the pharmacology department, they participated along with some clinicians. We selected our clinician depending on what we wanted to do and for what type of scenarios. So first, with the department of faculty, we wanted to have this workshop on rational prescribing with the clinicians, but it didn't happen. So we had a workshop, but that is with the junior faculty which was present in the pharmacology department and the resident. And we thought initially with the pharmacology department that we will have single drug prescriptions only. We will not go, because in 4 minutes, if the drugs are more, the students will not be able to tell that thing. So we just selected single drug prescriptions, common, which could be common causes of morbidity and mortality, and we can detect it in the OPD. So we made a list and then we confirmed that with the clinician. So ultimately what we selected is a nutritional iron deficiency anemia along with menorrhagia or bleeding piles, fever following vaccination, lower urinary tract infection, hypothyroidism, trichomonas vaginitis, treatment of naive obese patient in type 2 or diabetic mellitus, essential hypertension, uncomplicated all these things, temporal lobe epilepsy, and contraceptive measure. While developing the case scenario later on, we thought that contraceptive measures, even if we have to tell them about it, it will take a longer period than the 4 minutes, and then we drop that. Now, when we are communicating with the patient, it is very, very prescription to the patient. It is essential to have focus on the content. Even if you want to develop the communication skills, the student may have excellent communication skills and he is lacking in the content, then that is of no use. So we thought that we will give weightage to both the content as well as its delivery. So the content, how relevant content he organizes in a short time and how the delivery should be. So for developing these cases, we have to develop not only the cases, we have to prepare the written prescription. As the prescription should be written by the doctor, we prepared that. And we also prepared the scripts to be used by the student. So it is like a spoon feeding maybe for the student so that they can explain that prescription to the patient. So the scripts were also developed. And initially we wrote, 3 of us, we wrote those scripts, prescription and case description. And then that was validated and suggestion means rather than validated, I should say, the suggestions were invited from 2 groups. One pharmacologist, the faculty which was present in the department, and the clinicians. So we went to the clinicians who were like hypothyroidism, to the endocrinology or gynecological problems with the gynecologists, some with the medicine people. So we contacted those clinicians who will be helping us, or temporal lobe epilepsy with the neurologist. And then there was a discussion again. We wanted to have face-to-face meeting. That never happened. But our clinicians, they talked to us when we used to meet in an informal meeting, or I have to go and talk to them, or telephonically, and they responded to the email. So most of our conversation went as an email, and we discuss it and we come to some consensus. And I will show you later on one case scenario. Now, while developing the content, we went through the WHO guide to good prescribing. But the information, what they have it has mentioned that the doctor should ask patient, it was too much. And we thought that if we put all those things in our script, which is to be told to the patient, it will never be in that 4 minutes period. So we were searching for lots of literature regarding this, and we found a framework which was described by this Leopold et al. In 2014, and they called it as a 3R structure, which is focusing on the regimen, reason, and risk. And we added 2 more R and just expanded it, that it was reason, regimen, risk, revisit instruction, and revision statement. And we developed it in English, and then we got it translated into 2 languages, one Marathi, that is our state language, and one is Hindi, that is national language. So what this 5R framework was there, and why we thought that we should develop it? Because we thought we are going to do it only for 8 to 10 prescription, not more than that. but we should tell them the some process. So later on, the student should be able to develop a frame of using that particular framework, their own script, and we should not spoon feed them forever. So we thought that this could be a better one, and then in the reason we felt that they should explain the disease in simple language, why that particular drug is prescribed, when that drug will show is expected to show its effect, because sometimes it could be instantaneous, but sometimes the person has to wait to see the effect, and then the importance of completing the course. In regimen, because that prescription was given to them, they could easily tell the drug name, dose, frequency, duration. But if it is required, like for ORS, then they should tell how to prepare it. They should give advice for certain drugs, what is their relation to food, advice regarding the missed dose, like in the case of thyroxine for hypothyroidism, how to store, and any adjuvant therapy which is needed. While talking about the risk, they should tell us the ADR, but we didn't want to tell them all the ADRs which are listed in the textbook. So we decided that they should talk about two types of ADRs. One, the commonly occurring one, which are of high frequency, many patients will develop it, and they should give the advice whether it can be tolerated, whether a treatment is necessary, or whether to visit them and when to visit the doctor if they remain persistent or severe. And those serious ADRs, which may develop in few patients, but if they develop it and if they notice it, then the drug should be stopped and they should contact their physician immediately. Along with that, they should be told in certain cases that which concomitant drug should be avoided or which diseases they should inform the doctor. In the revisit instruction, there were few points: when they should come for the next follow-up, whether they should get the lab report along with them, when they should come earlier, when the complaints, for example, when the complaints they persist, and in which condition the partner should be treated. There were also revision statements. We call them as a revision statements, but at the end of that informing the patient, we felt that they should ask the patient whether everything is clear to them, whether they have any questions, and then that should allow the patient to ask questions, whether to ask the patient to repeat the most relevant points, and then again repeat whatever they have told if the patient has forgotten, and they should give the reassurance. Actually, the reassurance statements were only two. If for the short-term therapy, which is for 8 to 10 days, they should tell the patient not to worry, you will be all right soon. And if it is a long-term or lifelong therapy like hypertension, diabetes, or epilepsy, then they should say that if you take the medicines regularly as prescribed and follow the given advice, then you should enjoy you can enjoy a good quality, healthy life despite medication. So we simplified it as far as possible. And then, as I said earlier, it was 4 minutes were given. But when we wrote our scripts, we realized that whenever the long-term therapy is there for hypertension or diabetes, because they have to give the lifestyle advice also, hypothyroidism, it comes to 7 to 8 minutes. So it can't be uniform as 4 minutes every time. I will show you one case narrative, that is a post-vaccination fever. We wrote it as Ria, a 15th-month-old healthy baby girl weighing 12 kg, is brought to your clinic by her father, Mr. Shirke. Now, we kept it as father, but there was an objection from clinician because such a girl will be brought to the clinic only by her mother, mainly by her mother. But as I told you that we wanted simulated patient and we had less number of female students. So we thought that considering we have 180 students, we thought that let it be father. Ria had been given DTP vaccine yesterday in a municipal dispensary. Now, when we went to wrote it first, we had written initially MMR. So we were told that with MMR, the clinician said the fever doesn't occur. Means it is not a very strong fever boosting agent, inducing agent. when we said we went to DTP, we had written it as DTAP, that is a cellular pertussis. Again, the physician told us that fever is rarely occurs with DTAP, and he said that it is not given in the municipal hospitals. So he said that you put it as DTP, which is given in the municipal hospital, and it is ours is a municipal college. So the talk with the clinician really helped us to understand certain things. Now today, Mr. Shirke informs you that Ria is having a very high-grade fever since night. He informed that entire night cold compresses were kept, but the fever still persisted. You examine the baby, check her vitals, which are as follows. So we gave the information about the vitals, but we mentioned you inquire whether Ria has got other symptoms like vomiting, chills, etc. Mr. Shirke said that there were no other symptoms. Ria is well oriented and no signs of meningeal irritation are absent, and physical examination was unremarkable. So we have to make it as a very simple case. One can make it a very complex also with the diagnosis, but again, these were the second MBBS students, so we gave the diagnosis also. She's suffering from post-vaccination fever. And you are a treating physician, who examine her and write the following prescription for Ria Shirke. And we gave them the prescription. The prescription was exactly in the prescription form. It was not like only the drug as I mentioned over here, but proper prescription form on the doctor's letterhead with the signature, with the drug, with the therapy which is mentioned, was handed over to the students. So we mentioned about the syrup paracetamol, we're going to repeat it. Initially, we had written the cold compresses, but then the physician corrected us as a tepid water sponges. And he said, if you want, you can also explain them about it, but which we didn't put it in our presentation. Visit clinic tomorrow if you were insisted. And our question to the student was demonstrate how will you explain the prescription to the patient along with the information and instructions related to drugs. So this was what is expected from them as a competency. Means that time we were also not aware that though this is a competency, we were not thinking that the MCI is going to put it like this. So as I said, we wrote the script for the students, and I will not go through the entire script, but the script was written in a simple language, which runs into 1 page approximately. And in that, we also put something what the patient needs to report. This physician will not tell, or that student will not tell the patient, but what is expected, the student should know. So when and how to take medicine, because he is saying so many things. To again get from the patient all those things will be a cumbersome thing, and this will go on for making changes, and it will take a longer time. And therefore, we thought that we should have it only crisp one. What is more important is when and how to check medicine, when the relief is expected, and when to come early and avoid overdosing. And then appreciate that. And then suppose the person or that physician forgets something, then they have to add. And I hope that she will be all right soon, and do not hesitate to contact me if you need any help. We have to develop after that. Means this is not enough, because as I said that it has to be assessed later on, and we had decided that the assessment will be by OSCE. And once you said it is a OSCE, we have to develop a OSCE checklist for the student. And we decided that we will share the OSCE checklist with the student. So we will intended to train them as the OSCE checklist, which can be given as a handout. And now this has been printed in our journal. I will show you the word format of that OSCE checklist. Can you see the checklist?
Yep.
Hello.
Yes.
Yeah.
Yes.
So yes. So on the first column was our 5R framework. So the regimen, risk, revisit, and revision. In the second column, whatever I've told you about the expansion of that reasons, explain the disease, explain the reason for giving the medication, mention the drug effect, or that regimen, everything was mentioned in the second column. And the third column was left blank. What is the expected answer? And I will tell you what was expected for this particular checklist. Now, going back to this, my slides again, we had to train our faculty members for this. Means one, I told you about the rational prescribing for our junior faculty members, but we have to tell them about how to, though we have developed the case scenario, we had given to the faculty. So we have to train them that what is expected in the case scenario, especially for the second MBBS student. It should not be too complex. It should not be running into pages. It should be a small para which they can read and they can understand the diagnosis. And also we train them how to use the OSCE checklist. And we use this OSCE checklist for the students, for the teachers, for the assessment. So the assessment scoring of this was developing consensus with the teachers, and I will show you that checklist little later. We have thought that we will use our first year residents as a simulated patients, because first year residents usually don't come in contact with our students. From second year onwards, they remain present for our practicals. Sometimes they conduct the practicals, sometimes they conduct the tutorials under supervision with the teacher. But first year students, they don't come in contact with our the students. So we explained to them, we gave them those case scenarios, we gave them the scripts, they went through that. We had to explain them how their behavior should be. Now, this particular practical communication skill, you can take it to any level. You can make it complicated. If the behavior of the simulated patient, you can say that the patient is forgetful, or patient doesn't remember, or patient starts interrupting the physician and asking many questions in between. But we wanted to keep it as simple as possible. So we told them that you listen to what the students will be telling you. So your behavior should be of a very ideal model patient who is listening and understanding. And we also told them that if the students ask you that do you understand English, you should say that you understand English and let them say it in English. But at the same time, if the student wants to tell about whether it is in Marathi or Hindi and they ask you, you also say that yes, you understand that language. We also told them that the student will ask you that can you repeat this? So what points they have to elicit? So like students, what they should expect from their patient, this simulated patient also elicit those points. But while eliciting those points, we told them only elicit those points which have been told to you by the students. Otherwise, if they go by the script, they may say everything, but actually the students may not have conveyed those points to them. So we had to train them for that. And then we developed another scale for assessment, and which is called as SPSQ, that is Standardized Patient Satisfaction Questionnaire. You may or may not use it. We are not using it routinely nowadays, but you can use that time, because it was a project, we use this particular questionnaire as well. Now, our students were not used to OSCE. They were not aware what is meant by OSCE. So we have to give them a briefing about the OSCE, and this is very, very essential. When we are going to change our training, we have to inform the students in nutshell that what they are going to face and how they are going to, what we are going to do for them. We have to tell them about the logistics of the examination, because there were initially, when it was a project, we did a baseline OSCE and we did a final OSCE. So we have to tell them and what they are supposed to do in that. And we told them that language is no bar. You can use any of these languages. Before we start our OSCE and practice session, because it was a project, we have taken a written informed consent from the students, but later on, now last 4 years, it is a part of our curriculum. So we are not taking any informed consent from the student. But what we usually do, usually we usually means every time, we have a communication skill workshop for the students. Now, this communication skill workshop is conducted by 2 faculty members which who do not belong to the department. We can also conduct it, but we thought it is better that our students enter that particular workshop with different faculty members. So Dr. Santosh Salagre, who was a co-investigator in this particular project, he's been taking communication skill workshop across the country. So we requested him whether he can take it for our students, and we decided what should be the syllabus for that particular workshop. So it is mainly to make them aware of the communication, why it is important for the doctor-patient relationship, and he should come out with the elements of effective communication. And along with that, a physiotherapist, Dr. Maria, she also helped us, joined him, and both of them, they started conducting it. So first time we did a communication skill workshop. Followed by that, we did the OSCE, baseline OSCE, without giving them exposure to any of these scripts, cases, nothing was there. But we had seen to it, whatever we had given them, those lectures have been taught earlier in their classes, and they had an internal, terminal examination was conducted on those particular theory topics that we ensured. Then we had 2 practice sessions, giving them the resource material. Later on also, that resource material, which we have a group of students which is connected through a Google group, and all these 180 students which who come to our department, and through the group we gave them everything. We gave them the cases, the scripts, prescription, as well as the OSCE checklist. And then we had a OSCE final, and then we conducted the feedback. So we kept the same faculty members for both OSCEs, same stations and same group of students, but that is not needed for that. Now what we are doing is we are having the communication skill workshop, and we are having these 2 practice sessions, and we have put OSCE as a part of our internal assessment. So they have 1 station. So this type of workshop was conducted with all. I will show you how many students come to it. It is usually 60 students coming for this particular workshop. So we have, as I said, 180 students, and every time 60 students come to pharmacology for their practical. So there are 3 days we conduct the practicals for the UG students. So every day, every time we get 60. And we divide these 60 students usually in 2 batches, 30 students in one demonstration room and 30 in another room. So we conducted this workshop for entire batch of 60, and it was it was in a very interactive manner. The students were asked to do role play, also demonstrate. But the focus, as I said, was only on that non-verbal skill. We just asked them, why do they think of this? One of the pharmacologists who was present is myself and Dr. Rakhi Tripathi. Why you feel that our prescription should be communicated, or what can happen if they are not communicated? That's the only thing we covered in that particular skill workshop. But when they came for the practice session, the 30 students in one group, we had to have 3 facilitators for that. And they were then divided into 10 each, one facilitator looking after the 10 students. And now the facilitators, if you don't have these faculty members, you can have your residents as a facilitator, because the main job is done by the students and not by the facilitators. In this for the beginning of the this practical, we gave them 10 minutes. We give usually the 10 minutes introduction for the first batch where they underwent OSCE. So we found number of issues in that, and we discussed with them. Now we take some cues from that, and we explain them that 5R framework when they in the introduction. After that, the 5 minutes go in this allocation that they are going with this 10, 10, 10. They, in our big demonstration group, they go to that 3 different corners. And then facilitator divides them again into 3, 3, and 4. And 3 cases are discussed in one practice session. So we give them the 3 cases in a rotation. So each group of 3 gets case 1, second group case 2, and the 4 students get case 3. And they were asked to do a role play. Means initially we asked them to go through those cases, read those cases properly. If they have any difficulty, that facilitator will be moving in that group of 10 students. So they discuss with that student. We ask them to write down in their journal. Now that checklist is with them in the journal. So we ask them from the script, you pick up the sentences and write down in the journal where you find that they are relevant. And they understand that whatever the big script is there, that goes into that 5R framework nicely. And then some time is given to them using that, looking at the script, because otherwise they can't talk. But sometimes they are able to do that also because they have entered into their journal. One person becomes observer, and the one person becomes doctor, and other person as a patient. And then it starts not from the patient's entry to meet the doctor. We consider it that everything has been done, examination is done, diagnosis is done, prescription is written. So now they have to start from informing or communicating the prescription. So same way it starts, and the the doctor will communicate to the patient, and the other person will have the checklist. So he or she can tell those people at the end that where they have made mistakes. Now, after that, the entire group of 10 comes with the facilitator to one side, and then by rotation, we give that period of 30 minutes, that is 10 minutes per group, and we have to manage the time point. So 4 minutes for the presentation. As I told you, that short communication has 4 minutes are enough. So in 4 minutes time, they present, the others are listening, and there is 6 minutes discussion. Now, this discussion is mainly by the student, the observer from that particular group who has a checklist in hand, and the others. So it is an observer will tell where exactly what is missed, while the others will tell, just give the 2x2 feedback, like what they liked in that. So it comes to all that non-verbal cues and how he was talking very fast or slow, and how it is going, that will be discussed, and how to make it better. So they give the suggestion. So all that 10 students group will listen to 3 presentations done by the 3 different groups. And they have already acted either as a patient observer or the person who is doing the role of the doctor. Only for that group of 4 people, one person will not get opportunity somewhere or the other. Then there is a repeat session goes. Now again they will go back in their own group, that group of 3, and they will get now the different scenario. But the difference is that they have already listened to that and seen that role play. So it becomes really faster when they are putting it in their journal, writing it, everything, and they are talking with their, doing that role play. And they present that, and there is a 5 minutes wrap up. And in the second practical, we take 3 different cases. So in all, the students, they go through the 6 cases, but they may get chance to do it in 5 cases or so. We also developed the OSCE checklist. And as I said that it has a content and scoring, I will show you and tell you the problems in that also. We developed another one to see the quality of the communication. So we just developed it on the Likert scale, and only 3 points we have taken. What is the rapport with that patient? Whether the person was giving information, how the person is giving, and how the organization of the content. And we developed one global assessment, whether the person is incompetent, borderline, and competent. And I think that that is not needed. It was for the project. But we validated both this content OSCE checklist, which was done earlier, that was validated by the pharmacologists and clinicians for the content, and the scoring system was developed with the help of the faculty. And as I told you earlier, we developed this standardized patient satisfaction questionnaire, and also the feedback from the students and faculty, that was as an evaluation method. So I will show you this checklist. This was the earlier one, which goes to the student, but the second one, it has some instruction to the faculty who will be observing in that assessment. So you observe this student doctor standardized patient encounter, focusing on the content. A checklist is provided, and we ask them just to put a tick mark on the point the student doctor communicates, and do not interact with the student or the standardized patient. And then that checklist remains the same, but here now we have filled this what the sentences are expected. It may not be the exactly same sentences. The student is putting in his own word, but whether that point has come or not. And we had given the marking for that, so that thing indicates the score. But we don't ask faculty to add at that time. The faculty will tick mark or put the cross when it is not said, because students may or may not come in exactly the same order as we have written. While we had to take one decision right in the beginning, whatever may it be, the total marks we are going to keep it as 25. And for this checklist, for different drugs, the checklist marking vary depending on what sort of drugs it is. So we kept the marking for the revision statement, as all of you will agree with me. They are very simple and they are repetitive. So nothing much the student has to remember. So we kept the marking as 2.5, and we varied it depending on the others. Because for example, for paracetamol, hardly any adverse effects they have to justify to the mother. It is maybe sometimes the allergic reaction. Even hepatotoxicity doesn't occur with that 1 or 2 doses of paracetamol. They have to give the caution about not to overdose that. So they have to mention that it is a safest antipyretic drug. But if it is a carbamazepine given for the temporal lobe epilepsy, the list will increase. So the weightage depending on the drug will go on changing depending on that, and that will vary with individual drugs. So there is a variation in that. And we had to struggle a lot to bring it, and I can't say this is foolproof. Only thing, it is validated by the pharmacologists as well as the clinicians. The other scoring system, as I told you, it's regarding the quality, rapport, information giving and organization. We gave them the different scale from 0 to 5, Likert scale, and we told them to rate it and put it in this particular one. And regarding the global assessment, it was incompetent, borderline, and competent. So these 3 things which the assessor is supposed to do. On the other hand, the SP or SQ was for the residents, and we made it to 11.1, and it was rated on the poor, fair, satisfactory, good, excellent. So this is regarding their skill of delivery, because they didn't talk about the content. So making you feel at ease, speaking slowly, showing care and compassion, being positive, explaining things clearly, explaining things in language easy to understand, explaining the risk involved in the medication without scaring or creating anxiety, informing plan of action, and helping you to revise relevant points, listening carefully to what you have repeated, and overall, how will you rate the satisfaction? So with these particular 3 skills, which the residents evaluated them, we then conducted the OSCE for this. And this OSCE, I just want to show you in this picture. It was done in a demonstration room, and you can have 3 examiners coming to sitting in the room. And the students, they move from one table to another. At each table, there is a student is there, and our resident is there who serves as a patient. And he also jots down the point as the student informs him or later on. And the facilitator or the examiner will sit, and he will just go through the checklist which is provided to him, and just do the tick marks. And then we have to, other person has to collect those papers and give the final marks to the students. What lessons we learned out of that? We found that it is a time consuming process when we developed it, and that is why if you are going to do it as a communication skill, I urge you to start as early as possible, because it will only we can't develop it. We have to have our clinicians in the picture, and with clinician, you know that how much time they have, so we have to be after them to get it. And email, I felt, is the best communication method, because clinician, our clinicians got convinced when we told them that how important it is. So the time went into discussion with our faculty also. We have to have the flexibility in plans, because we have decided something earlier, but then as I said that we couldn't have face-to-face meeting, and we had to manage that timeline. We had, as I said earlier, and I'm making the same point, that we need to interact with the physician. We learn many practical aspects when we talk to our clinician. For carbamazepine also, when we had put whatever is from the textbook, what we felt are common and what is going to meet it, but our neurologist insisted if there is some rash, then they should not, you can't stop anti-epileptic. So you have to contact your neurologist immediately, because that rash can lead to the it could be Steven Johnson, it can lead to. And secondly, she said many patients on carbamazepine, they complain of diplopia, especially when it is a peak. So after taking the drug, after 2 hours or something, there will be diplopia. They will have double vision, and you have to inform that patient that not to stop the drug because of that, because tolerance develops to that. And I don't think that we have seen it in the textbook. Then they also strengthen our cases. They made it as real life situation as possible. And we can't assume that the theory knowledge gets translated into practice, because as I told you earlier, we have all those theory was taken, the internal assessment was, those topics were there, but still when we conducted that baseline OSCE, we found the scores were poor in content, in delivery, as well as the quality. Means I was not expecting content delivery, and students can say anything, whatever comes to their mind sometimes. So we have to practice, that practice sessions are essential. We have to tell them that they have to behave as a physician, otherwise they will start looking at you. They will sometimes to give some information to the patient, or they will smile, they will have some, they will feel shy. And I have also seen some of the students, when they were said that the language is no bar and you can talk in Marathi or Hindi, beautifully they explain the patients. So we have to give them that chance. We found that it improved when we did our this analysis. We found that their communication skills did improve when we compared the baseline OSCE with the final OSCE. The students demonstrated improved confidence. The standardized patient overall expressed the satisfaction. But one thing happened, that in the initial period, the students were not knowing much of the content, as well as the delivery was very slow, comfortable. But later on, while for final OSCE, they knew that they have to convey that much information in 4 minutes time, and that's why they started speaking very fast. So the score decreased on that particular one aspect, but overall satisfaction score was high. And faculty members, they expressed quite, they were satisfied with the experience of that, and that is why for the last 4 years it is being continued. We took the faculty feedback on the structure program, and we Clinicians, I will tell you that they appreciated it most. Means some of the clinicians, they were saying that why you want to do this and all, but they contributed a lot in development. And later on also we developed that as a videos, and they helped a lot. So they have agreed. Actually, they said that we can use these cases in third MBBS, but that has not happened. It has remained only for the second MBBS, but it has a scope to go into third MBBS also, making it little complicated. And as I told students that they also felt that 150 students, that quite high on each of these different things what we asked, that they became better, they became awareness of their weaknesses, awareness of their strengths, could relate to the patient's concern. Not only that, later on the students approached us and they said that they would like to make the videos on this 5R framework. I don't know whether they made it or not ultimately, but they were very keen to have this type of practicals. Coming to that next part of it, means this I will not tell you in detail, but we also developed, no, this video was not developed by us that time. We borrowed it from our chest medicine department, and they had a small video on use of meter dose inhaler. Anyone can develop that particular video. And we developed an OSCE checklist. And this OSCE checklist was not as big as our drug content checklist. It was a very small checklist we developed for meter dose inhaler with spacer and without spacer. I have that video also, which is a 2 or 3 minutes video. But we developed based on that video. We had those steps. So in our practical on dosage forms, we showed them those video, and then we showed them the steps, and then it was again given to them, so they could have both the things with them. And whenever the student comes for the examination, we had the OSCE on this one as well as the another one, that is intramuscular injection. And the students were aware of the checklist, and we tell them that you don't tell us. Otherwise, if you give them the meter dose inhaler in the hand, they will, and you ask them how to use it, then they will tell you each and everything as if they have mocked and they are telling you. But when you tell them, now there is a patient in front of you, and you explain the patient how this is being used, we found small lacunae in that. Means half of them, they not actually half, few of them, they didn't even remove the cap. They didn't know where the cap is. So it starts right from there. And we found that how we asked them how they will count, because the person who is taking meter dose inhaler can't keep on watching on that clock, or they can't keep on counting also. They are so engrossed in that activity. So how they will count it when you are saying the count 10 seconds or 5 seconds. So all those things were there in the video. And when they were explaining, we found that they can remember it quite well. And we could give them a good feedback at the end of that. So that was one thing we used. And the similar way, it can be done for other practicals also, or the other devices also. And Guide to Good Prescribing mentions these steps. Only thing is that when we are taking those steps, even for the intramuscular injection, the steps are there. You will find n number of checklists on the net, in the book, but try to develop it with your own faculty, because there are so many questions came when we develop those checklists, when that whether the student will fill the injection first, that's syringe first with the drug, or he will first prepare the patient and they will fill that. And on the net, I will tell you that I think AIMS had a workshop long back, but they have, if you put AIMS and drug delivery system, you will get that their booklet or the manual for that workshop, and it has beautifully explained a number of things. So you can give that to the students for self-directed learning, and you can focus your practical on only on the few things. I think that's all I wanted to tell you. So my plea to you is that if you are putting this communication skill or use of devices in as it is expected by MCI, we have to start preparing it. Even if you will be conducting it later, it will be maybe in the not immediately when the student will come to us in October. We will be doing general pharmacology, so it will be next year. But you don't have to do on each and everything. Last time someone said on the insulin, we can tell them about the storage condition. Yes, that is a good topic. But start doing it right from now and do it for only few things. You need not do it for the entire curriculum. And the MCI doesn't expect us to do it. MCI expects us to do it to make a start, develop few, do assessment with that, and keep on adding it, and we can share it also later on in a group, our checklist, and then cross-check it and strengthen it with more and more inputs. Thank you. Hello.
Questions, anyone?
Hello.
Yes.
Yeah. I'm online.
Please raise your hands. Dr. Kamal. Dr. Shantanu.
Yeah, I'm here. So it was just excellent and very challenging. Dr. Rege has
Yes.
given a lot of effort. We all appreciate that the amount of effort behind it, not just one person. It's a teamwork, huge teamwork, and that's what she has shared with us this evening. Uh, I echo what she has said, that there is, and she has demonstrated that how learning can be fun. And the what I most liked is that getting the students do it in groups of 3. Okay, uh, through this experience they also gain experience, they also do the role play, and by this they also learn it the right way. And finally there are a lot of areas for each uh, stakeholders to learn from this experience as we develop this. Now when I was listening this, I also had uh, one area of concern that I think I should also express here, because there is always sometimes there is a tendency amongst us to also go the easier, to take an easier path, uh, instead of trying to develop our own module or our own exercises like this, what Dr. Nirmala has done. There might be a tendency to also borrow what other department has developed and try to follow that. I think that is the least we can do, because it is not just because it is a new challenge that has been given to us. uh, each department should try to emulate this and try to develop this in their own way, and that is how they can also get involved into it. All the faculty can get involved, senior faculty, junior faculty, the residents, and also, as Dr. Rege has mentioned, that while developing it, she had to go back and forth, interact with the clinicians, and that also has a additional value of developing rapport with the clinicians. Okay, and some of them has also said that they can try it in the third professional. So what could be more rewarding than that? So overall I am really very much, I appreciate this, and I hope that the different departments will take the principle of it, cues from this what we have heard Dr. Rege today, and try to develop. We all will try to develop at our own setting, at our own department, try to emulate what Dr. Rege has done, not copy what Dr. Rege has done. So that is what my first response to this presentation after I have heard Dr. Rege. Excellent, fabulous. Thank you very much.
Thank you, Dr. Tripathi. I also
Hello.
agree.
Hello.
Yes, sir.
Yes.
Madam, it was really an excellent session. I am very sure that all the participants and even faculty members will be benefited, and they will prepare the sessions, communication session, because there will be 7 such communication sessions. Now, one thing which I wanted to know is how to certify it now, because this element will come in almost all.
Yes. Sir, with the help of the checklist only, means we have to develop that checklist. As we have developed that could vary from institute to institute, but developing the checklist only is a one solution. Based on that, we can certify. We have to decide internally that how much information which is given is enough and for the student, and we have also seen that everything is not they should not give, but that we have to decide that they are giving the core information and they are not extra information. So that faculty has to decide of the local colleges. It's otherwise very difficult.
What I could understand was that certification indicates the level of proficiency or efficiency. Now, is it that we decide that 80% times he should be able to do, or 70% of the times he should be able to, or 100% of times he should be able to do?
100% is not possible, no, sir.
Not
It's
possible,
never
correct.
possible. So we have to decide certain core features that the student must say, and based on that, if that has been said, then you have to certify him. So
Can we
So
add
that
that
is
element into the
Nirmala,
checklist itself?
uh
Can
-huh.
we
yeah,
add
Dr.
that
Yes,
Nirmala,
element to checklist?
can
yeah,
we?
because Dr. Nirmala, because you have already developed that checklist and also
Uh,
objectivized it, you have given the scores. Now what you can do is, I think you can say that the minimum criteria is, or minimum mark you have to, in order to get a certification during the formative assessment itself, is say 80%. Until unless you achieve this 80%, for you this particular item is not cleared. Something of that sort we can think of. Whether it is 80% or 70%, that can be decided. But it is good that you have validated, you have given the score. And but I was also thinking of another concern, or rather, it is always there for any OSCE or OSPE, that it has to be properly developed in the department itself, because in order to evaluate, in order to assess using the OSCE or OSPE, you require many sub teachers or sub examiners. Okay, so
exactly.
an external examiner who is coming during the final examination might not be tuned to what is being practiced in that department. But in such a situation, the external examiners, they have to depend on the uh, junior faculties. Okay, they have to take it into confidence in order to help and assist in this assessment of the using the OSCE checklist. And the external examiners can act as the observers. So this is a challenge
Uh,
again. And
yeah.
given our experiences, what we have seen. Yes, Dr. Nirmala, yeah,
I was
go
just
ahead.
saying that is why I fully agree with your concern, and that is why on that for the teachers or assessor checklist, we
Yeah,
write those lines also, because we don't leave it just like students that you give it, because then there could be variation. Because, for example, if they have to say uh, adverse drug reaction, so that 4 adverse drug reaction will be written over there, so the examiner can look at them and they say that okay, he has just said 2 and not the other 2, and those 4 are the critical ones. So something like that we have done, but it is very difficult. Means if someone can say about a simpler method than what we have done, I will be very happy, because otherwise there is, it is validated, we are using it, we have seen it work, but still I have my own doubt about that. It is a complicated checklist. It is not
yeah,
simple as a procedural checklist. That's what I want to say.
right. That was also what I was going to tell you, that it is very comprehensive, but it is possibly has to be simplified. Okay,
Hmm.
and maybe we may not try to assess everything, okay, in each session.
Yes.
I am very sure that this
Otherwise it may
framework
be
will
very
be very useful
difficult to
to
implement
all.
actually. Right.
This is really good actually, and this framework will be
Yeah,
useful for many of us actually.
but at the same time I have my concern that we may tend to copy this framework. I would rather advise that let us each one of us or each departments of ours should try to develop through this uh, through this pain of developing this thing, and then only they will develop the passion, and they will actually implement in the most appropriate manner they are supposed to do. Otherwise there is I have a extreme concern that in another six months there will be that what they call it, the notebooks on how to deliver, how to conduct practical sessions in CBME pharmacology curriculum. So if we once that comes, we are lost the game. We have lost the game. So we
Yeah.
have to avoid that by all means. No assistant books, no notebooks on this. So first of all, we have to accept that, take a place that we are not going to look for a notebook for these CBME pharmacology in the new curriculum.
Yeah.
One more suggestion is there, and that is, can we assign one communication skill to one group of the participants, even right today?
Yes.
Give them time to
Yes.
prepare.
Yes. We can.
Hmm.
There is one Dhanya Palapalli.
Hello,
Yes,
but
Dhanya,
the
you can.
only who will
Sir.
do it? I think. Who will do it? I think you must. Hello.
Dr.
Good
Dhanya
evening,
Palapalli.
madam. Good
Yes,
evening,
yes.
madam.
Yes.
Thank you, madam, for this excellent session. I wanted to ask two queries about the role plays being conducted. Were there
Yeah.
scripted role plays which the student had to enact? And second question, what about the emotional elements of the students where they assessed? Because communication skill, the patients want this emotional content of the doctor also. So what about that?
Yeah. So that is why we had first thing that it was a scripted this thing which they have to enact. But we told them that they can modify it. Means we didn't whatever the line was written. We said that this should come in their presentation. They need not mug up those lines, and many students did that way. Means they translated it in their own way, and they did not use our script. In reality, initial practice session they used it, but during assessment and over the years, I'm finding it they are using their own way. Regarding the second thing, the emotional this thing, that is why we had that communication skill workshop. So there, those faculty members took care of that empathy with the patient, how they should talk, how they should behave. All those things were covered in that particular skill workshop. So delivery was covered in that, and we focused on the content. And we emphasized on them that both content and delivery, both are important. You can't have one have content and the delivery is bad, or you have you behave very nicely with the patient, but you give all wrong instructions. That is totally wrong. So that we have to do.
No, but Dr.
Uh,
Nirmala, in your list of one list of questions that I have seen, a lot of them
uh,
actually try to capture the emotional component in the delivery, in the communication, and the many of the soft skills they can also be captured through those questions. So I
that
have
was by
seen
the
some of
rest.
your questions.
Yes. No, that is
Right.
by the resident. The patients, the simulated patients captured those delivery and those emotions, and the faculty mainly captured the content, mainly content.
So why can't the faculty also try to look at this soft skill components also? So that should be
No,
also
because what
assessed
happens,
actually.
no, that can be done, but what means it
Yes.
was, it becomes too many things the faculty has to do,
Yeah,
because
that is
you remember it's only for 4 minutes. So in 4 minutes,
Mhm.
immediately after that, the next student will be coming. So we told them just to tick mark and concentrate on the content, and where the simulator patient was listening to all the way to doctor who is role playing that player,
Right.
and that person can miss is at the other end, so he can immediately note down that how the doctor is behaving and how he is
Yeah.
feeling, because it is his perception, his or her perception.
But it's good. You have made it so comprehensive. It can be simplified. Some of the core
Yeah,
components can be kept, and of course, you have
exactly.
given emphasis on the contents. Yeah, that is to be kept. Uh, well, very nicely done.
Yeah, Dr. Nirmala's presentation has been excellent, and I think all of us should use it as the pioneering path that she has broken for us. So we know how to traverse on this because she has already done it, and you can see how to go about it. And as Dr. Shantanu also was saying, let us keep it in our own way, very much simpler. And before any textbook in pharmacology comes for us, I think why don't we all make up a textbook of our own with the
Yeah, exactly.
consensus? That is just a
Dr.
thought. Excellent.
Dr. Kamal, I can hand raise. Dr. Kamal, please unmute. His hand is raised. No, he has to unmute himself.
Hello? Hello? Can you hear me?
Yes,
Can
yes,
you hear
madam.
me? Yeah, Dr. Kamal
Yes,
here. Yes, Dr.
yes,
Kamal here. Yeah, madam,
yes, sir.
yeah, it was an excellent presentation, and you have you have put a lot of work. I think it is a broader area, the skill of communication, since I am also working on it since past couple of years. So there were two queries that you have told me, that you are having a scoring system also in your study, or the
Yeah.
what is being done at the department. Does you
Yes,
have a scoring system?
yes, scoring system for the OSCE checklist.
And it has been divided in three categories based
No,
on the
no,
scoring.
sir. No. We developed three types of scoring system. One is to the content, which is a total marks as or score as 25, given to the various things they have said. The one was Likert scale, giving how they have organized the content, how was the delivery. That was the 3 points were taken, and for that we developed the Likert scale. And one was a very global assessment, because we wanted to see what is the difference in the checklist and the global assessment. Actually, you can use it, that keeping a borderline incompetent and competent. But what happens, when we use that checklist or skill type checklist, we can give it to the student and tell them that this is the point you miss. If I am going by the global assessment, I may be right. The student may be a borderline or competent or incompetent. But then for the individual student to give feedback, it becomes difficult, because I don't remember that time that why I
Yes,
have
yes,
put him as a borderline. So
yeah.
it was mainly for the project, and I feel that we can have a OSCE checklist one that is enough. Means I'm favor of those OSCE for the undergraduate students who are totally naive for these different types of skills. Better to go by OSCE other than the other global assessment, though they are used in practice. And it is said that even you have an expert, then the global assessments, though they are subjective, they are really they are better than the checklist. But when we are showing the checklist to the student later on, we used to show them, then it is always better to have the checklist, because you can tell the student that this is the place where you are going wrong, and they can improvise on that.
See, since patient communication is a broader area, so it is also involving creating a good interpersonal relationship and showing the empathy with the patient, exchanging information or making the treatment decision. It is not covered in that, or
No,
is it also covered? It is too short.
That is covered by another checklist, and that the
Okay.
simulated patient had that checklist to cover these
Okay.
other interpersonal relationship, because he was the patient that time and he was
Yeah.
receiving the information. So he was the best judge. That's what we felt to
And
have that.
moreover, we have to judge in a 4-minute time. It's a quite short time. So as Dr. Shantanu has told,
that's
we
why
need.
we recommend a single drug.
Yeah.
Single
Yes,
drug
yes.
only. If you have more drug, then you require more information for that. But
Oh,
we can decide particular aspect and we can develop it. For example, oral contraceptives we didn't take, but we can just develop a OSCE checklist for the adverse effects of the oral contraceptives, or we can just develop an OSCE checklist for how the oral contraceptives should be administered. Something like that, we can break it down and make a simpler and smaller one. That is also a possibility.
Don't you think in the pharmacology department we need to give more stress on the pharmacotherapeutics or pharmacology aspect? That is managing the management of the medications, explaining the medications, how to use them, dosage, frequency, demonstration of the method of the administration, or if adverse drug reactions, if any. So I think these 5 or 6 more important points will also take little bit time, and it may not be possible to cover all in 4 minutes of time. So at my department, what I was doing I have kept it in 2 parts. Pharmacology and pharmacotherapeutics part, I have separated it from the other part that is being covered in the medicine, where is greeting and introduction with the patient, active listening is involved, and examination skills and body language of the person who is having communication skills, attitude and empathy towards the patient. We are not covering that. We are covering only pharmacology and pharmacotherapeutics part. That is the management of the medications, how to use those medications, dosage, frequency, because it is also very, very important to explain it. Sometimes we think that it is a job of the pharmacist, but as of in a developing scenario of the clinicians, it is a part of the physician to learn all this, to communication skills of the what the pharmacist is expected to do. We need to develop those skills also. That adverse reactions, if being developed with the use of any medications or ensuring the therapeutic adherence, all these are the part of the communication skills.
Yeah.
What is your say?
No, I think that can be done. That is what Dr. Shantanu was saying right from the beginning, that each department should have their own way, look at it from the different angles, develop their own way, and just they shouldn't copy what we have done, or we shouldn't copy what you have done. But after maybe 1 year or so, once we have got the experience of that with the different departments, that time we can share with each other and take the best practices and incorporate in our this thing. That there is no harm in doing that. But if you just take yours or mine and others start taking it, then it will be monotonous, and we are now not that creativity, whatever is there, will not be there. So it is better to get other people's people also to do it. And as I see here that Dr. Veena Nayak, she has left now, but she has said that we should take one condition and develop it. That can be also done. Start developing it, and then we understand that how pleasurable in making it for, and students also like it. Means they ultimately they learn pharmacology in a better way also, because they have to communicate that to the patient. So that is their job as a physician later on. And many physicians,
Anyway, it is an excellent effort on your part. I must congratulate you for the same. It is an excellent presentation. Excellent. You have covered each and everything, I think. Thank you.
Thank you.
Yeah. May I make a comment?
Yeah. Yes,
Yeah.
madam.
What I wanted to say was this is a milestone. When we are talking about drugs, we are starting at the first level, that is pharmacology. Ultimately, any doctor, whether it is the nurse or the pharmacist who is telling about the usage of the drug, the vicarious responsibility is on the prescribing doctor himself. And so the
Definitely.
communication onus is on the physician who is prescribing. Now, whether he has time or not and how he manages it's a different thing. And we
Yeah.
in pharmacology, in our goal to making the IMG, we are doing the first step. And in this kind of a way, we are in the right direction. And that will be honed up like a milestone by the third year, fourth year. That's how it goes. So we are doing a good start. Thank you, ma'am. Excellent.
So should we call it a day? Yeah, it's 7.
Yeah.
Ranjana, sir, we will take her as the last one. Ranjana, unmute yourself if you are there. Hello, Dr. Sahasrabuddhe.
Yes, ma'am.
Oh, she's there, no?
I
Her
think
hand is raised. She has left.
Dr. Ranjana
Sahasrabuddhe. I don't know. Anyway, then we will
Yeah,
leave
hello,
it.
hello.
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 Huh?
Yeah, can you
Yes,
hear me?
Ranjana.
Yeah, now it's
Yes, yes.
unmuted. Yeah, I think what was just said a little while earlier, since this is the beginning, it'll be a really good idea if we can actually develop a bank, you know, each one taking up some therapeutic aspect and developing these role plays and assessments. So, and as you said, after each one of us puts in the efforts and develops some topic, some content, finally we pool it so that we have a huge bank of these role
Yeah,
plays
but
and
Dr.
scenarios.
Sahasrabuddhe, as Dr. Shantanu said initially, we should not
Yeah,
just do
that would be
one.
very nice.
You do a group of things, do it
Yeah,
in your
each one,
college,
each
be the
one
responsible
yes,
students, then we can share it and we can develop a bigger bank. That can
right.
be, we may find the best way also. What we have done is not the best. I'm not saying it is perfect also. I have my own queries
But
related to that, which I
it
didn't
is
share with all of you.
creditable, but madam, it is creditable to have started it, taking the proactive initiative. That was really nice.
But we can develop, all of us can develop, and we can develop it in a
Yes,
nicer way,
definitely.
and we can have it
Yeah.
in future. And there is a group already formed, so we will be working
Right.
together ultimately. Yeah.
Yes, this is a
Okay.
nice group for collaborative working. So that's, and thank you very much for a very nice presentation.
Okay. So Dr. Shantanu, should we? Hello, Dr. Sanjay. Dr. Sanjay.
So,
Should we end the?
yes.
Yeah. Okay. Thank you. I'm ending it for all. Huh?
Okay.